Welcome back. The topic that we were discussing earlier was fostering treatment expectations around improving function, quality of life, and reducing the impact of pain on the patient's life. And pain should be a secondary goal. Okay. Along with that, we saw that exercise has an impact on musculoskeletal system, cardiovascular system, and the brain. So, understanding these three things, what will be our management? Our management should involve exercise involving musculoskeletal system, cardiovascular system, and the brain. Now, looking at interventions. So, when we are looking at interventions, we will divide it into acute pain interventions and chronic pain interventions. So, acute pain interventions, what would be? Assessment would include analysis of functional biomechanical deficits, example muscle strength imbalance, decreased endurance. So, would be addressed through specifically tailored exercise program or whatever the intervention would be. So, that would be planned on how, what were the symptoms, what were the signs, and what would be the management. Now, pain would often be a useful guide here. As we have already discussed earlier, pain should be respected in acute pain. That means that VAS should be respected in acute pain, right? So, it is a useful guide for determining the intensity and frequency of exercise activities. While on the other hand, let's look at the intervention goals for chronic pain. For chronic pain, we may have to look at the first aspect, definitely. That is very, very important, because without that we would not do. So, we'll have to look at the functional aspects as well, biomechanical functional aspects. But along with that, we may have to look at fear avoidance, depression, excessive deconditioning, in addition to the functional biomechanical deficits, and lead to progressive loss of function and affect, which could lead to progressive loss of function and loss of function and affect the quality of life. The primary goal to include the brain for improving the patient's function. That means that we had discussed exercise has an impact on musculoskeletal, cardiovascular, and the brain. The brain involving the psychological aspects, and that involves the emotional aspects and the cognitive aspects. Both of them have to be addressed in the management. And exercise intervention should focus on the biomechanical issues in context with the cognitive components. Okay. Now, with this we come to the key points concerning the exercise prescription. So, some of the things that you have to understand and remember is that understanding contemporary pain biology. That means that first we need to understand the pain, how it is divided, what are the signs and symptoms of the pain. For example, if I say the pain is a dull aching, or the pain is sharp, or the pain is burning. So, what do we understand by these terminologies? If the patient comes and tells me that yes, I do have a dull ache pain. Do you know, I'm sure you all must have gone through your basic pain physiology of understanding about the A delta and the C fibers. So, understanding these two concepts, that A delta is myelinated while C fibers is non-myelinated, and then they also carry pain, okay, and also that they do have dull ache, and dull ache pain is more to do with the visceral pain, and the sharp pain is more to do with the dull ache pain is to do with the visceral pain, while sharp pain is to do with the somatic pain. Okay, so when this is there, but when we talk about the neuropathic pain is something to do with the nerves. So, how does the pain in the nerves feel? It is more like a burning sensation, electric shock like sensation. So, all these are important keywords for us to understand, to differentiate what kind of pain process is going on in the patient's body. So, based on that, you would plan of an exercise prescription for that patient. The second thing is frequently reassuring the patient that it is safe to move, pace up despite their symptoms. Now, why is this important? Because as we said, it is a chronic pain. So, they already do have emotional component which is involved. So, you need to tell them that they are going to get better. But do not give false hopes. You need to look at the patient as understanding that if you have to treat the patient holistically what are the conditions. You do not confront the patient, okay? You do not confront the patient and say, no, you cannot get better. But you will try to challenge the patient's own thought process and make him feel better. So for example, if I say that the patient will say, no, I do have pain and I was taking exercise therapy, but the pain did not subside. So you can, as a therapist, if probably you must have asked that, okay, so the pain did not subside, but what about your functional activity? Was it better? Yes, of course. The patient says that, yes, of course it is better, but the pain did not subside. That means that there has been an improvement, but the patient is not under. So what do you think you have achieved in the last 1 week is what the therapist asks the patient. So the patient says that I've been able to take care of my children at home, and I have been able to help my wife with activities like cleaning up the house and cooking. So do you think that you feel that you have done something constructive and meaningful in the last week? So he says, yes, of course, because my wife feels happy that I have been able to spend some time with her, and the kids are also happy because I've been able to interact well with them. So in that case, do you really think that you have not improved from what you were? So the patient says, no, I think I'm better. And that is where you have changed the concept when a patient came to you initially saying that exercise, I am feeling better, but the pain has not reduced. But there has been a change in the function, although there has not been a change in the pain, which means that here the idea of pain education comes, where you make the patient understand that it is a slow process. You need some time for the pain to subside, but neither less that there has been an improvement in your quality of life and function. Okay, and that is the reason why it is very important that you reassure your patient that it is safe to move and there is no problem and you can do it. But do not overdo things and instigate the pain which is already there. Okay, you do not challenge the pain, but you challenge the patient to overcome that pain with the help of exercises. Now coming to exercise prescription should be timed as opposed to pain contingency. So again, as I said, you will look at what is the primary outcome. The primary outcome should always be your function, and pain should always be your secondary outcome. Then coming to ready-made responses, because sometimes the patient may say that I don't know why this is happening to me or what. So you need to be prepared with certain positive, affirmative responses which will help facilitate your therapy in a meaningful direction. Then coming to the next point, that is exercise should be individualized, because as we have seen, again as an experiment or as an activity that you all can do and try to just feel that as I said earlier, you can just try to sit in different positions and hold that position for some time. Will there be a varied response among the group that you have chosen to do this activity? I'm sure there would be. Why? Why do you think? Because every individual's pain perception or threshold is going to be different. That is because your pain perception is depending on your experience that you have had. So for you, the maximum pain that you have had may just have been an injury. But for a patient who has had an accident and just survived an accident and has a pain from that, that would be his maximum pain perception. So whenever you are marking, it will be based on the pain perception that you have experienced as maximum. So which means that it will be individualized. You cannot say it can be generalized. So with this particular understanding, it has to be individualized and it cannot be generalized. Although there can be a framework. As I said, there can be a generalized framework based on which you can do a permutation and combination and still customize it for your client or patient. It has to be enjoyable, because you have chronic pain does not just affect an elderly or an adult. It can also affect a young child, or it can also affect an adolescent. Okay, so when you want to understand or get a meaningful intervention, you need to look at that it has to be enjoyable, whether it is a child or whether it is an adult. You would always want to make it enjoyable, because after a certain period of time, any activity which is not enjoyable does not sustain, which means that there will not be any adherence. And for a sustained adherence, you need to make it enjoyable. Then looking at the patient goals, as I earlier mentioned, you cannot forget the patient goals, because finally whatever you're doing is for the patient, right? And with a level of supervision specific to the patient. So initial, the next slide we will be, the next few slides we'll be discussing about the level of supervision that is required. But initially, at this point in time, we can definitely come to a statement of understanding that we need to have some amount of supervision. Do you agree with this point? Yes, we do need to have some amount of supervision. The reason being that initially the patient has a maladaptive understanding about pain. To change that behavior, you need to have some supervision, that if the patient feels that no, he cannot do it, you need to motivate the patient. And how will you motivate the patient without supervision? It's a little difficult. And that is the reason why you may have to be there with supervised exercise program for a few weeks before you terminate or you reduce it to translating it into a home-based therapy. Then coming to, you may also have to start, as I said, not all patients may have, you can start with moderate intensity. Some patients may want, like patients who are having a VAS of 10, is it possible, is it that you do not give exercises for a patient who has 10 intensity? What do you think? Do you think you can give? In my opinion, you can definitely give it. Because again, as literature says, mobility is very, very important. So it can be a very low intensity exercise program, but movement is very, very important in the treatment of pain, right? Now coming to the next one, closely observe and monitor the exercise practices, seek and provide feedback and correct the poor techniques. Because most of our patients that we are going to be dealing with would have some amount of compensatory mechanisms which they would have had, for which again supervision would be essential to correct that maladaptive technique which they have been adopting as a relief of their pain strategy. Encourage your patients to self-monitor exercises. Like, you need to ask them to keep some diaries, because sometimes they may say that no, I've not got. So you'll have to, if you keep diaries, it can help you in a lot of ways. One, understanding the compliance, understanding the adherence to exercises. Then you can also see how the improvement has been, because that can lead to progression, and it will also give a feedback to the patient of seeing an improvement. So when you see something in front of your eyes, isn't that more stimulant for doing more activities or more exercises? Yes, it is definitely a added positive response. And then place emphasis on developing or restoring movement, confidence and quality. So restoring a movement, quality and confidence is very, very important in these patients. Now coming to evidence-based exercise management. Now when we look at evidence-based exercise management, that means there has to be some key for exercise prescription. So the key to the exercise prescription is identifying and promoting strategies that facilitate actual participation in exercises, which means that the patient's involvement is very, very important and is the primary goal that you need to make sure that the patient is involved in his or her own process of treatment. Okay, patient and the family members both, because as we saw, there is an interaction between psychological, social and biological factors, which means that the family members are also equally important when it comes to therapy, because that can also influence the treatment process. Now when we are talking about exercises, we also need to see that by and large, when we look at articles and this thing, we always look at adherence is somewhere an important factor that can be used as a negative in terms of exercises, because normally there is decreased adherence to exercises. That means when we say decrease, it is talking something about barriers. So what are the barriers to participation in exercises? So here we would divide it into three components. One is patient factors, one is environmental factors, and one is healthcare delivery factors. When we look at the patient factors, we would to give you one or two examples of each. One would be fear avoidance. So fear avoidance, again, I'm scared of doing the exercises because I feel that if I exercise, I may hurt myself more. And that is a reason why I do not want to try exercising. Okay, that can be one barrier. Second barrier would be, I am too old and I think that I should, at this point of time or at this age, I should not be exercising, and I think I'm okay not exercising. That could be another thought process. Okay, now strong beliefs that can exercise be harmful. So strong beliefs is like you feel that, okay, if you exercise, definitely there is going to be some adverse effect. Okay, if I exercise, and that is why I would have this adverse effect, because I've seen my relatives or I've seen my friends having the same thing after exercising. But are you aware about the situation, in which context they are talking about? Have we evaluated whatever they are saying is right or wrong? I wouldn't say that they are wrong in whatever they perceive, but the situation in which they are may not be applicable to your situation. So generalizing it may not be a right thought process, right? So these are some of the patient factors that may influence or create barriers to participation in exercises. Coming to the environmental factors. Environmental factors like lack of access to a place to exercise. Oh, today I wanted to exercise, but there were a lot of guests at home, and that is why I didn't have place to exercise. Or I wanted to exercise, but I don't have the proper equipment to exercise. I do not have the proper kind of atmosphere to exercise. Or potentially there will be that I would say that I believe that they perceived, or there is real lack of time. So I do not have time, or there may be genuinely a lack of time. So all these can be examples to explain the environmental factors based in barriers to participation in exercise. Now coming to the healthcare delivery factors. Lack of attention to the psychological and the central nervous system contributors to pain. Now that can be a very, very important. So I look at it as an acute pain, and I would look at just the root cause. I would just look at it like a tip of an iceberg. So I would just look at the pain is there and at that joint. Okay, and it has been there for 3 months and more. Right? 3 months and more. Right now there is no noxious stimulus, which is there is no potential tissue damage that has been seen, but I still have pain. Right? So in this context, I try to treat the patient with some form of modality or exercise, and I keep treating, and then I realize the pain is still not subsiding. And again, I look at it as pain as my outcome, still not subsiding. So the patient says that I don't know why this is not happening, and the patient must be also thinking why this is not happening. But have you missed some component here? It is 3 months and the pain is there. Okay, and it is persistent. The pain is coming and going, but there is no potential tissue damage. So do you think you're missing on something? Yes. Maybe we have not considered the central sensitization phenomenon. But for that, first you need to evaluate the patient from that thought process and confirm that yes, it is a central sensitization or it is a chronic pain and needs to be addressed in a slightly different approach. Right? So these are some of the examples of healthcare delivery factors. Now, there are, when we did this presentation, we looked at about a lot of articles, but one that needs to be mentioned was a Cochrane review, that we saw a review of 21 Cochrane reviews, which was RCTs. Okay, so they have accumulated all the RCTs and done Cochrane reviews, and this study is a review of those 21 Cochrane reviews of the RCTs. Okay, and of course all the other, there are a lot more studies which have been involved in making this evidence-based literature. So in this were the conditions that were addressed in terms of chronic pain. So chronic pain, exercise and chronic pain, the conditions that were involved are osteoarthritis, rheumatoid arthritis, fibromyalgia, low back pain, intermittent claudication, dysmenorrhea, mechanical neck disorders, spinal cord injury, post-polio syndrome, patellofemoral pain, CRPS, temporomandibular conditions, migraine, and ankylosing spondylitis. I'm sure there would be many more conditions, but this is what, to our knowledge, is what we have tried to get as many as we could, and the literature that we have accumulated shows that these are the conditions which were studied in relation to exercise and chronic pain. Now, the outcomes that were used in chronic pain were physical function, psychological function, quality of life, adherence to prescribed intervention, healthcare use, attendance, adverse events, not death. Then death was another outcome, and self-reported pain questionnaires. Now coming to the level of supervision that we were discussing earlier, exercise programs that are individualized and supervised have been recommended for chronic muscular. So as I said, initially you require some weeks of exercise. But again, literature says that supervised exercise program, there is no minimum number of supervised exercise sessions before progressing to self-managed home therapy. So there is no evidence to say that how much of supervised exercise program do we need for progressing to self-management program. Supervised exercise promotes treatment adherence and supplements supervised sessions with home exercises, educational worksheets and materials which can improve adherence, which is very, very important, I'm sure, in the treatment of chronic pain. And for traits such as low back pain or low exercise self-efficacy patients, fear avoidance behavior, higher levels of supervision may have to be considered. So as I said, it is individualized. So some patients with such conditions may require a longer term of supervision followed by a home-based exercise protocol, while others may require shorter duration of supervised exercises followed by home-based exercise program. Now the components of exercise that have been studied are flexibility, range of motion, strength and resistance. In strength and resistance, they've also included isometrics and dynamic exercises, endurance, which is aerobic, and also muscular endurance, and balance, proprioception. Coming to, endurance, when we look at, is both muscular endurance and the cardiovascular endurance. Now coming to modes of exercise. The modes of exercise they have seen in literature is all sorts of manual therapies. They have seen exercises, but the ones that have been seen in the Cochrane reviews is mind, body and motor control like yoga, Alexander, Tai Chi, special exercise protocols targeting specific impairments, spinal stabilization exercises, motor control. Then they have seen land versus aquatic exercises, and they have seen there is a positive outcome with all the exercises. So there is no superior exercise program like flexibility is better than aerobic, or aerobic is better than resistance, or resistance is better than the same, because there has been an effect on most of these exercises in some of the other conditions. Because again, as we see, there are certain specific conditions, there are certain generalized conditions like general matlab widespread area of pain like fibromyalgia example, and specific conditions like low back pain. So the exercise protocol will definitely differ between one or two, with priority being maybe in one condition the priority will be aerobic followed by resistance training, in the other resistance training followed by aerobic. But they will always improve with a combination of multiple components of exercise program. Now looking at land-based versus aquatic exercises, positive outcomes have been demonstrated with supervised land exercise program that either simulate or duplicate work and or functional tasks. So what they have looked at, whenever it is more functional task activities, simulation, they have shown better results than just doing an activity, right? While resistance aquatic exercises can also improve pain and functions in patients with chronic musculoskeletal pain conditions. Now, the literature also shows that both of them have shown similar effects. So it's not like one is better than the other. But however, again, some patients who prefer aquatic, you can do aquatic program, and some patients who prefer land-based can be done with land-based. So preference of the patient is also an important factor when you decide whether you want to do a land-based or aquatic or the modes of exercise that you choose. Aquatic exercise might be preferred for individuals with very poor functional tolerance and or heightened levels of pain and distress initially, followed by land exercises. Now coming to the treatment dosage. Now if you see from this Cochrane review, which is 2017, there was 21 articles, as I said, 21 articles which were selected. There were a lot of articles, but 21 were selected for depending on the inclusion exclusion criteria, and there were mixed results. So we have tried to compare and give a general protocol of how was minimum, how much was maximum. So the duration varied from single session to 30-month session. Frequency varied from 1 week to 5 weeks duration per week, and intensity varied for aerobic from very light, that is less than 57% of heart rate maximum, heart rate max, to 85% of heart rate max, and for strength it started with 30% of 1 RM increasing to 80% of 1 RM. So this was how they had done it. Now coming to the duration. Duration is 15 minutes to 1.5 hours. So if you see, there was a varied response, or there is a huge variability in all the factors, from duration to frequency to intensity and to duration per session. Okay, so understanding this, we looked at more articles and we came up with a general protocol which has been given in one of the articles about aerobic exercise prescription and resistance exercise prescription, and they have followed it as per the ACSM guidelines. So it's like a framework, but you can definitely make a new prescription generalized. As I said, generalized prescription is just to make it as a framework. It cannot be used for therapy directly on your clients. You will have to use it as a framework and make your own protocol for your patient and then plan it. So coming to the aerobic, as you can see here, intensity, they have divided into low intensity, moderate intensity and high intensity. Frequency is, you can do it like less than or equal to 2 times if you're doing, if you're starting it in the initial days, 2 to 3 times, and then you can also go up to 6 days, because ACSM also says that 3 to 5 days a week, or you can do it every day, then the intensity and the duration will come down. Then coming to the intensity, low intensity, moderate intensity and high intensity as per the RPE, you can look at it. Then the time from 20 to 60 minutes and less than 20 minutes with exercise intolerant, less than 20 minutes for patients who are exercise intolerant. And consider shorter interval interspread exercise with exercise modalities for in the initial phase, probably because they may not be able to do a lot of exercises at one stretch, because you need to understand that you're conditioning. So conditioning starts with shorter bouts and then increasing the dosage and the time duration. Type is modalities involving continuous and rhythmic exercises that engage major muscle groups but do not exacerbate symptoms. You never try to exacerbate the symptoms. And progression, you can commence with an RPE of 8 to 10 grading to up to maybe 11 to 13 as tolerated by the patient, and you can also increase, because if your baseline has already been moderate, then probably you will go to a higher intensity. That is all patient specific. Now coming to the resistance exercise prescription. So resistance exercise prescription, as you again can see, it is intensity is 1 RM equivalence. So you look at low intensity, moderate intensity and high intensity. Frequency, intensity, time, type and progression as described in the earlier has been described here. And then now this is what we have created. We have the articles from where we have tried to get it has created a framework, but this can always be modified, as I've already said earlier. So now if we have to come to the end of this session, we would try to summarize of what we have learned in the last few things, like a takeaway home message, which is important that you need to remember. Exercise in general is therapeutic for a wide variety of chronic pain diagnosis, but it has been difficult to show that one particular approach is superior than the other, as I've mentioned. So you need to understand what suits best for your patient based on your clinical knowledge and your clinical reasoning skills. Patients have multiple barriers to successful participating in exercise, including patient-specific factors, environmental factors and healthcare delivery factors. Hence, this needs to be evaluated and made a note of before commencing for a planned exercise session. Evaluation of a patient before exercise prescription should include a comprehensive biopsychosocial assessment and determination of the goals of the exercise program. Successful exercise prescription requires coordination of care and good communication between the physician, the therapist, and the patient. Successful exercise prescription requires patient education regarding the impact of exercise on the nervous system, education targeting the fear avoidance beliefs, and education about the details of how to do an exercise program and what are the things that you need to keep in mind. So if something happens, for example, if you're doing this exercise and this is what happens, so you need to give them a solution of if this happens, what would you do, and if this happens, and if that happens, what else will you try to take a note of. Okay, so with this we come to the end of the session. The references that we have used in this discussion are the following. Thank you.